Dola Prata is a physician and medical demographer from Angola, an associate professor in residence in the School of Public Health at the University of California, Berkeley. Dr. Prata also serves as the scientific director at the Bixby Center for Population Health and Sustainability at the University of California, Berkeley, and the medical director for Venture Strategies Innovations. Dr. Prata has obtained her MD in Angola and received an MSc in medical demography from the London School of Hygiene and Tropical Medicine. She has conducted research in Africa, Asia, and Latin America, and her current research focuses primarily on sub-Saharan Africa. Much of her recent work has focused on the expansion of the use of misoprostol to control PPH. Please welcome Dr. Prata.
Thank you very much, and good afternoon, everybody. I'm so happy that there's still people to listen to the last session. But it's the last session, but also very important, trust me. So what I will share in the next few minutes with you is some of ideas from not so much why do we need community distribution, because at this point, at the end of the afternoon, in this audience, we know that we actually know that we need community distribution of misoprostol to prevent postpartum hemorrhage. But we're going to be looking at some of different approaches and challenges that we have been used, we meaning the large community, including the organizations that I'm a member of, but also many others. Some of you are here represented that are working with us in the field and other local organizations in each country. VSI has been working over the last few years. We've been conducting what is now around 9 operations research in different countries, looking at different ways to reach women at the community. And the imperative to address the problem of postpartum hemorrhage, the main cause of maternal mortality, especially for women that deliver at home, is, as we know, the disparities in maternal health. So many disparities. It starts with, between regions, between countries, within countries, between rich and the poor, and the ones that are the sort of the most disadvantaged are usually the poor women, the ones with a lack of access to a skilled provider or that live very far away from a health facility. So, and that gives us the premise to actually look at the potential of what can we do for this main disease by looking at the trajectories of women. We have about 9 months to capture these women, or maybe less, depending on when they decide to seek help or that they realize that they're pregnant. But when they're pregnant, they can either go to antenatal care or not. During pregnancy. So, and then at the delivery stage, they can be at a health facility, it can be at home by themselves with the family members or friends, or with assistance of what we call today traditional birth attendants, either trained or untrained. What misoprostol brings, very quickly, so just to review, is to change the game in terms of postpartum hemorrhage and be able to reach these women with this potentially life-saving drug. Because we can reach them, for those who come to the antenatal care, we can reach them there with a message and with the drugs, so that if they don't come to deliver at the health facility, at least they have the drug at home to use it themselves. Or the TBA has the drug at home, to use it at home. Or if they don't come to antenatal care, there's a large number of different names, depending on the country, of community health workers or health promoters that are out there that can be used to reach women with the message. And I'm calling community health worker just as an umbrella for this, any outreach worker at the community that can be used to reach women during pregnancy, close to delivery, or at the delivery, if the woman knows when they deliver at home, if the woman knows that someone in the community does have the drug to protect her. So, and very quickly, what this brings us is basically we're looking at different opportunities to maximize the existing human capacity. Yes, I went back a little. Just to finish this point, to maximize the human capacity. And when I talk about the human capacity, I'm talking about both at the community level and at the facility level, and everything in between, everyone that can reach a woman with any health promotion messages. And also to maximize health-seeking behavior. So a lot of these women in many places, they do come 3, 4, 5 times to antenatal care. And we can use that venue also to reach them with a specific message about PPH and misoprostol and give them misoprostol at that point in time. Not very different than many other drugs that are being distributed during antenatal care, folic acid, multivitamins, in many places where HIV is high, nevirapine. So we're just following the same pattern on how to reach women that have contact during pregnancy and then do not have contact at delivery. So, and this is an example of the potential that exists to maximize community-level resources. And this is an example from Nigeria. So each of these names here in each bar is a different community in rural areas around Zaria in Kaduna State. And you can see that there are different ways, and we try them all, to reach women with a message. And when we ask them later on after delivery, what was the most important source of misoprostol information, even among those quite small in size compared to northern Nigeria communities, there's differences among the communities. So where do women go for information? Who do they trust? Who is the first one that they go for information? And you can see here that TBAs can play an enormous role if in cases where women do not go for antenatal care, and that's the main way that they deliver. But drug vendors can also, pharmacists can also play a role, and community health workers in many places, friends, family, sort of a multitude of vehicles that can be explored to reach women with information. In order to maximize the healthcare seeking behavior, I'll bring you an example of Tanzania, where the project in 4 districts that we have, the 4 districts total about 1 million population, looks at distribution of misoprostol through antenatal care for those women that deliver at home. They can actually use misoprostol at home. And as you can see, the misoprostol is actually distributed at the 32 weeks gestation. They can have the information before, but the drugs itself is only at 32 weeks gestation. And as you can see, very close to the percentage of women that come to antenatal care at 32 weeks, we can actually reach those women with the drug, so that there's a degree of comfort that they might use this drug at the time of delivery. So the idea is that during antenatal care is not just the distribution of misoprostol, an NC visit, an education session about PPH, but it's also there is a component, a community awareness component about birth preparedness that most importantly mentions the importance of delivering in a health facility, and only in the event that they cannot reach the health facility, then they can use this drug. And all that combines to try to reduce postpartum hemorrhage, especially actually at home births for those who don't arrive at facility. So at the end, if you have communities that have high level of home births, most of them, such as in the case of Zaria in Nigeria, most of them deliver by TBAs or by themselves. What we want to achieve is that these deliveries can actually have some degree of protection with a uterotonic agent, because these women are not going to have access to Amstel. As you can see, if that is done with a very strong community awareness campaign, what you get is like a high level of deliveries that use misoprostol even at home births, because as you can see, the access to an injectable uterotonic continues to be very, very small. And you can see that even with the degree of effort to reach those women is very, very important. I will address that a little bit later, because even in a pilot, you can miss what I think is a significant number of women, in this case, 17%. So what needs to work and why? And I will divide this, we will discuss more in the discussion session, but I will divide this into two parts, at the programmatic and implementation level, and then at the policy level. And some of it was already mentioned in the previous session, because they are actually the same, whether you are doing clinical work or community work. But I'll address some specific issues that are more sort of relevant for policies that address community level use of misoprostol. So it is important to know the community. And the reasons is that who do they go for healthcare? What do they do? Are facilities available? What is the pattern of the sort of the behavior of that community in terms of accepting healthcare services or community healthcare services? And this is very important, because we might have in our policies, and every country has, that women should deliver in a facility. Women should deliver with a skilled attendants. But we also know that the reality is that that is not improving very fast, and that is not the expectation that a significant change in the next 5 years is going to occur is not there, because the past tells us that we're moving. There's progress in many places, but we're moving very, very slowly. And we have to address the women that deliver at home. However, it is also important to have a very effective information and education and communication campaign, so that the knowledge about the drug, the risks of the drug, the side effects of the drug, so all of that is known not just by the health providers and a few members of the community, by everybody, because at any point in time, we know in the community a woman that is pregnant that we can help assist with the drug or with information to minimize sort of the misuse and the incorrect timing of taking the drug. It is also important to integrate misoprostol into existing community-based maternal health interventions, so that the use of misoprostol for prevention of PPH doesn't stand alone as a vertical program, but integrated in other existing community health programs. And in many places, many countries have SMACs, the Safe Action Mother Groups. Some countries have health extension workers and other different level of community outreach out there that should be tapped into, so that when we train community health workers for HIVs, when we train community health workers for safe delivery, that we actually, or any kind of prevention, that we actually use those same venues and opportunities to bring in postpartum hemorrhage, given that is the main cause of maternal mortality. But it's also important that at the same time, that even though a lot of people do not believe that you can have two strategies, one that improves services and tries to address the fact that women should deliver in facilities, and one that addresses those who cannot reach the facilities. But it's possible to do. And it's possible because from a public health perspective, and I'm talking as Ndola right now, it's actually ethical to address both at the same time, while efforts are being made to improve facility deliveries that need to improve, especially delivery rooms in developing countries that are very, very poor quality. We also cannot forget that a large number of women do deliver at home. If you look at the countries such as Ethiopia and you look at the demographic and health surveys, in the last 10 years, they haven't moved. Almost 90% or more than 90% of women continue to deliver at home. And that hasn't changed in the last 10 years. And that is of significant importance to address those who deliver at home if we want to tackle the main cause of maternal mortality with the expectation that we can address maternal health in general. At the policy level, what I would like to address here is the importance of the commitment to protect all deliveries from PPH wherever they occur. And it's not just in paper, but reflected in policies, reflected in resource allocation, reflect human and financial resource allocation for those programs, and in implementing strategies with both public and private partnerships to address both the deliveries that take place in a facility that we know need significant improvement and those that take place at home too. Also, the importance is that at the policy level, we address the issue of scale. And it's the reason why is this important is like no matter how beautiful and high level effectiveness we have in our programs within areas of confinement in districts where we work, if we don't have scale, we're not going to have an impact in maternal health. And the scale up, for those of us working in nonprofit organizations, is important to have in mind that we are not alone going to be able to scale up any significant maternal health program. We need the collaboration of all, and more importantly, that the government needs to be involved in these negotiations. It is important to work towards a comprehensive package of maternal health services, but in those services, it is also important to have community-based distribution. Right now, I'm saying distribution of misoprostol because it's the only commercially available with evidence that we can do at community level, but later on we might have Uniject, we might have other things that we can have that. And when I say comprehensive package of maternal health, if we want to decrease postpartum hemorrhage, we need to have in this comprehensive package not just misoprostol, not just oxytocin, not just the anti-shock garment. We need to bring all of those interventions together and have it available because, as Suellen mentioned, all of those will be important at different stages, with different levels of providers, and within communities they will address different issues that one might not be able to address. So it's important to have all of what I call all of the arsenal to fight this big disease, which is postpartum hemorrhage. Just to give you an example to look at how to reach women. One of the things that is important to have into considerations when you talk about a drug, when we talk about a device that needs to reach women in the community, is to look at all of the avenues, both public and private, that are available, and see from when it's manufactured and distributed in the country, what are the most important channels, the fastest, and the ones that reach the largest number of women, which at the end are our main clients in these circumstances. And the private, I'm listing here not just the clinical level, but also community groups that sometimes are very, very important to reach women with the message, so to change the health-seeking behavior so they can then either access information and the drugs at the pharmacies, at the different clinics, or just knowing the existing of some NGO programs in their areas. So at the end, what we want to achieve is a protection from PPH. And what I'm calling here protection as a loose term is number or percentage of deliveries that take place that have at least one uterotonic at least one uterotonic agent is used for prevention of PPH. And I want to show you here some example from different countries according to where the misoprostol is being distributed. And the bar with all deliveries, so all births, includes both the misoprostol and oxytocin or ergometrin, depending on what was available. But it's also important to note the differences between countries and the level that is represented here in terms of the level of effort. It's not that the drug is less effective, it's the effort to reach the women that is important. And if we lessen that, either with the information, either with the ability to reach those women using the channels that I showed in the previous, all of them, then the coverage would be significantly lower than other places when we actually use all the multiple channels. The other thing also to have into consideration is that in many of the sites, and that's why I mentioned before that improving labor ward services, improving access to other uterotonics at the facility level is very important while we're working in the communities, is that we realize that the IEC campaign that we usually have in those countries actually is designed to move women from homes to the facilities. But they still have the misoprostol that was given during antenatal care through the community health worker or the ANC provider. And what happens in many instances is that those women arrive at the facility and there's no other uterotonics. They're delivering in a facility using the misoprostol that was given during the community distribution, and some of them during antenatal care. So some challenges and concerns for implementation, and I'm presenting this as trying to answer some questions that are still out there, and many more will come during the discussion. And one of them, is it safe? Will women take the correct dose? And as you can see from some of the examples that we have, yes, those who take misoprostol, vast majority of them will take the correct dose. They do follow instructions. It's very easy to follow instructions on misoprostol for PPH prevention. I think I had another one. No. So the other challenge that is actually is the place of delivery. Would a program that addresses through community-based distribution of misoprostol that addresses PPH at home births, will that impact the efforts towards increasing facility deliveries? And this is an example from Tanzania, which is a legitimate concern. This is an example from Tanzania, but we've seen in many other countries that is actually, it doesn't really impact so far, but we need to continue to monitor and make the necessary corrections as these programs are scaled. The other challenge is, will women know? So they're delivering at home, they have the drug at home, the drug is not 100% effective. Will they know what to do? And our colleague from Bangladesh has mentioned and showed that blood collection tools can be identified and devised that are culturally appropriate, that women can use and they can follow as it might not be 100% accurate, it might not be 500 mLs, but is a red flag, it's an alert, so after which they can use it. And they have been doing this very, very well. Is it acceptable according to local beliefs and local belief systems? Because we know that in many places, we've worked in northern Nigeria, and there's so many cultural practices around PPH that is already, but we've seen that they were actually, women will use misoprostol. Some of traditional birth attendants that are actually traditional healers will use misoprostol, the ultimate test is, will they buy misoprostol? And the vast majority of them, even those who did not use misoprostol, would do it. So very, very important. The other main question is, especially for those of us working into distribution of misoprostol to antenatal care, is antenatal care providers are very busy. Would they actually do the work, extra work, so to speak, that we're asking them when we're talking about misoprostol distribution? And as you can see, the main source of information has been the ANC provider in many places, even though the IEC campaign had other providers in the community community, providing information about it, but the misoprostol was actually given to the ANC provider. So it's possible to do. So in conclusion, there are various ways that women can be reached and that various ways that can be explored. What I listed here is what we know have been tested in the field with a certain degree of success. Now, and hybrid models can be put together. Provinces with high antenatal care, provinces with the low antenatal care, such as in Mozambique, we actually have both the ANC and the TBA at the same time, because the key is to reach all women. And if we do have that into account, we can make a dent into decreasing postpartum hemorrhage. Thank you. Sorry.
I think these last two need no introduction. You've already heard them before.
Well, good afternoon. I'm talking about the community mobilization and engagement strategy of the CCPPH project in Nigeria. This project started in 2007, and we started with the middle part of the continuum, which is the facility component. And we wanted to be sure that the hospital facility structure was firmly put in place to be able to accept a larger number of clients that would be the product of the community intervention. So we didn't start the community intervention until late May 2009, when we had put the facility structure firmly in place. And just before we started, we commissioned a survey, a community survey around the intervention primary health centers. And the findings from this survey largely shaped the implementation strategy. We are not really very surprised about most of the findings of the survey, but I think one thing I should mention, which came out very, very clearly, is the difference between decision and permission. Now, when we talk about decision-making as the first barrier, we tend to, place a lot of emphasis on that. But surprisingly, during the survey, we found that a lot of women actually would naturally make the decision to seek for care when they have an obstetric complication. But the delay, or the source of the delay, would be the permission. And there are two different things. So whereas a woman would make the decision to seek care on her own, the husband or the responsible male in the household may not necessarily give the permission. And that, in most instances, is due to the fact that there is usually some financial implication. If you give a permission for a woman to go to the hospital, then you would have to give her money to take a transport, and then you would have to give her money that she would use as user fees in the facility. So that actually came out very, very strongly during the community survey. The goal of the intervention was actually to increase awareness about the new technologies in the model, and also to be able to mobilize the communities to access health services within their communities when emergencies arise. The specific objectives, have to do with increasing awareness on the danger signs, particularly on PPH and eclampsia, which is also one of the things that we do. We also want to increase ANC attendance and health facility deliveries. It's very remarkable that in some communities you find that almost 100% of women attend for antenatal care. But it's the facility, it's the deliveries in hospital facilities. And one of the things we found in this survey is that most women regard childbirth as an entirely natural phenomenon. They would only come to the facility when there is a retained placenta, or when there is excessive bleeding, or when there is a complication. And of course, the last objective is to ensure that every woman, every pregnant woman has a birth preparedness plan in place, including a transportation system that they would access in the event of an emergency. We put down 7 strategies that we would follow to achieve some of our objectives, but all the communities, in all the different communities where we're intervening have quite different strategies. So for instance, we do awareness creation in all the communities where we work. Transport systems are not really a problem for communities, say, in Lagos State, because they have a statewide ambulance service that almost everybody can access, by just calling a number. But you cannot say the same for communities in northern Nigeria, where they don't have access to any form of transportation at all. So in some of those communities, that is really more of a priority. The 7th strategy, which is using the NASG at the community level, we didn't quite get to using that because of the restrictions from the authorities on using the NASG at that level. So this is an example of one of the transport systems that we have, and there are so many different systems that we use depending on the community. In this community, it's so remote that they only have a car, or they only see a car once in a week on a Friday, which is the market day. At all other times, the community is totally inaccessible because there is no vehicle going that way. So the only thing that they have thought to use, which they think they can sustain, is to use motorbikes. When this woman had a home delivery and she had a retained placenta and she had some bleeding, and she was able to sit down on the motorbike. But for those women that are really very sick, they have a cart. They have a 4-wheel cart that they attach to the motorcycle, and then they transport the woman to the facility. In other communities, they use police patrol vans, to transport women. In other communities, it is usually a well-to-do member of the community, like the traditional chief or a local businessman, that would volunteer to give out their personal vehicle for the communities to use when they have emergencies. For most of the emergency vehicles that we use, whether it is the Okada or motorcycle, or whether it is the taxis or the buses, the numbers that the community members are to call in the event of emergency are very clearly displayed in very prominent places. So it's either in the primary health center, or it's in the local mosque, or it's in the traditional ruler's house, or even the TBA's place. And these are very common places where people usually access information on the transport systems. So at startup of the project, at the community level, we did some identification of the important gatekeepers in the community, and we really wanted to understand what the structure was like around the intervention PPH. Most importantly, we worked with existing community groups. There were these groups called the Ward Development and the Community Development Committees, which were set up by the Primary Health Care Board of the country. So it was quite easy to reactivate them where they were not very active, or to, co-opt other very powerful and influential members of the society to make up these groups. We also used community coalitions, which were set up by a now defunct USAID project called Compass, mostly in northern Nigeria. They were very, very powerful community mobilization group, so we used them a lot to do some of these things that we're doing. We had a participatory project plan, in the sense that we worked together with members of these groups to formulate their work plans and budgets. And we did the advocacy together and gave them a lot of support to carry on with their activities. I had mentioned earlier that the implementation structure is somewhat different. So different communities were allowed to adapt, the model that they felt was most useful for them. So whereas some communities really pursued, having a sustainable transport system, others were more interested in generally raising awareness about the danger signs of pregnancy and making women to have preparedness plans, including getting their husbands to give them to not only help them in making a decision, but to give them permission, you know, followed, of course, with the financial part of that as well. So we gave the community groups training on advocacy and community mobilization skills, and we support them to meet regularly to discuss progress and the implementation plan. And one of the things that we really do, and which is linked to the community, to the facility aspects of it, is to these blood donation drives that we do in the community. It is somehow linked, I said, because there are still challenges with getting safe blood for transfusion in most of our intervention facilities. So a lot of the work we do around awareness creation is also to make them understand that it is only when they come and donate blood voluntarily that you would have safe blood at all times in the facilities when the need arises. We also give them technical support to monitor and fine-tune the emergency transport systems that they have in place in most of the communities. This is an antenatal class, you know, with women holding these their birth preparedness cards. So during antenatal, the trained provider helps each woman to make an individualized plan. And most of the time, this plan also includes getting her, depending on, of course, on the context, helps her to get permission from her husband or her spouse to attend in the case of an emergency. And they have them written on these cards, and you know, they are displaying those cards now in the facility. We do house-to-house sensitization using different community events, like when there's a naming ceremony or when there's a wedding ceremony or any community activity at all. We use the opportunity to get into the communities at the household levels and engage the men and the women in the household with the specific messages that are relevant to that community. We also do a lot of engagement with the TBAs. We don't quite, you know, train them in the traditional sense on how to conduct deliveries or how to do any complex maneuvers, other than to give them some orientation on, you know, infection prevention practices. But the most of the work we do with TBAs is to encourage them to make timely referrals of their patients to a health facility. And remarkably, now we have a model in Nasarawa State in north-central Nigeria where the midwives are working with the TBAs, you know, they actually allow the TBAs to come into the delivery room to give companionship to the women they have referred from the community. And this is really a new thing, because until very recently, the hospital maternity was a complete no-go area for the TBA, because they were usually scorned by the midwives. We do a lot of engagement also with the men, who are the real decision makers really in the community. This is a traditional naming ceremony. So we have had local imams or religious, Islamic religious leaders trained under a different Pathfinder project. So we use those imams to sensitize the men, you know, on the need for them to be involved in some of these things that we do. To date, we are intervening in 36 communities around our primary health centers, and 77% of those communities have a community-driven emergency transport systems, and this varies very widely across communities. But the most important thing is that all the transport systems are community-driven, and the communities have actually the communities own those transport systems, you know, and these are very, very sustainable things, because most of the time the community members make even small donations to ensure that maybe they buy fuel for the vehicle that they use to transport women. about 243 women have been transported from very, very remote places to hospital facilities using these transport systems. We've had about 76 sensitization events where we've reached over 200,000 people with specific messages on safe motherhood, particularly PPH, prevention, care and treatment. We have engaged 477 traditional birth attendants in these 36 communities. And the most recent blood donation drive that we did in the community, where we have the solar blood bank that I talked about earlier this afternoon, we've had about 100 pints of blood donated by the community members. Thank you.
Believe me or not, this is the last presentation. I think nothing has left actually for the presentation, because all the speakers, they have speak about how to mobilize the community and innovations like community distribution of misoprostol. But I will tell you, apart from presentation, little bit stories about the community mobilization in India. So why community mobilization requires? What is meant by the community mobilizations? There are two ends in our country. At one end, it is little bit funny, but it is a fact. In our country, for the women in rural area, there are conservative women. Except open air defecation, they are not allowed to go outside the home without permission of husbands or mother-in-law. This is a fact. So imagine the woman is going for antenatal care independently outside the home. Distance may be 2 or 3 kilometers far away. It is very difficult for her. Geographical, social, financial barriers. Apart from this, woman empowerment, the terminology is very good, but it is in the rural area. To empower the woman, there are lots of issues to be highlighted at the local level. Another issue, the one midwife in India is looking 10,000 population, and one primary health center is for 30 to 50,000 populations. So how this institutional delivery can work? So that is why the 28 million pregnancies occur every year, out of which only 50% are happening at the institutional level, and that is because of incentivization of institutional delivery. The pregnant women are going to the hospital not because of for her safety, they are going because of incentivization, because their husbands are getting $30 for that delivery. This is a fact. The motivators for promoting institutional delivery, she is getting $6. And who is not happy? The service provider. The midwife, doctors, they are not getting anything for conducting deliveries. The most unhappy person is service providers, and the workload has increased 10 to 15 times. The delivery is happening at the month, only 10. Now it is happening 200 to 300 delivery because of incentivization. And that is why the quality care is not there. That is where the role of community mobilizations comes in. Another end is, we have interviewed some of the pregnant women before community mobilization starts. We ask them, why you go to the hospital for the delivery? It is just because of incentivization. Really, that doesn't want to go to the hospital. Why? Because whenever they go to the hospital and labor room, any male health workers or male doctors comes to examine, PV examinations, without consent, without counseling, without looking at the reproductive rights of the women. All windows are open. So these are the very, very sensitive issues to handle it. That is why the most of the women that doesn't want to go for institutional deliveries. So that is why it is, as Dola says, it is imperative to address the issue at the community level. When we go to the government level to address the issue of misoprostol and before start the community intervention activities, we say why government of India is not ready for misoprostol. They say, we know misoprostol is very good. There are a lot of evidences are available. We are not against of misoprostol, but issue is, we are at the one end, we are promoting institutional delivery. We are promoting by giving incentives. If we promote community distribution of misoprostol, that will go wrong message in the community to promote home deliveries. Recently, Government of India has stopped disposable delivery kits. If you understand disposable delivery kits, because if we give the disposable delivery kits, again the message goes wrong to promote home deliveries. So DDK has stopped, and that is why the misoprostol is not working in India, not because of WHO. Government of India knows the fact about the misoprostol, it is effective, but because of this issue, they are not ready at the moment. Generally, I don't fail to convince the government, but unofficially the government person says to me, we will definitely do it, but initially at this moment till 2011, we are focusing on institutional deliveries. And definitely within couple of years or 3 years, definitely Government of India will invite all the donors and partners for community distribution of misoprostol without research. Internationally, there are plenty of research around. The approach, we are doing saturation of the community through medical officers, frontline workers, and leaders. We are creating enabling environment at the community level to sensitizing of decision makers at village levels, and the community about the how to go, where to go. Already the Shabnam has spoke to it. The mainly we are reaching 2.3 million populations and 63,000 pregnant women. So we are working this community mobilization activities in the 3 states and in 1144 villages. It's a big task. 3 states, 1144 villages. Population is we have to reach 2.3 million populations and 63,000 pregnant women. It's a big task. The issue is training is not rocket science in the community mobilization. We can't train because there are so many sensitive issues that are attached in the community mobilizations. Training doesn't work. So Pathfinder is doing directly training of all these frontline workers, 3,576 frontline workers. Fortunately, with the recent strategy of National Rural Health Mission, nowadays in every village there is a one frontline worker at this moment. So to train these three, the strategy we have changed it. It's 6-hour training sessions, and we are doing how to counsel the pregnant women and decision makers. We are not training anything because Government of India is already doing so many trainings of frontline workers. What is ANC? What is IFA tablets? What is PPH? They know everything. But they don't know how to do the counseling. What is mean by interpersonal counseling? So we have identified 6 topics in the community mobilizations, and we are not training, we are doing counseling with the role plays. 6 role plays, 6 topics, that's it. Our training finishes. There is no lecture, nothing else. Role play from the participants, they do role play, and easily they understand the message, what is key messages or what is punchline in interpersonal communications. That's how we are doing training. So, sorry. Oh, what happened? This disappears. Oh, this is also tired, I think. Then we train frontline workers. They go to the community. So every frontline workers visit minimum 6 times to every pregnant families. So the target is pregnant mothers, decision makers as husbands or mother-in-laws, and the community members. So she will do separate group meetings for each and every stakeholders. So ultimate outcome of our community mobilization is birth preparedness and complication readiness plan. This is where the new terminology is there for Government of India. They know everything, but this plan is not available at the community level. The importance of this, we have not targeted anything to reduce PPH like in clinical intervention, which I talk in the morning, reduction of CFR and proportional mortality rate. Our target here is every pregnant mother, every eligible family in the community, they should have birth preparedness and complication readiness plan. Irrespective of anything. She should know where to go in the hospital during emergency. What are the danger signs of PPH? What is meant by the contingency fund? What is meant by the emergency transportation? So that is where this plan is. That is our main outcome. If we go and monitor, if the pregnant mother knows all these things, that is our outcome in the community mobilization. So this is emergency fund and transportation are in place with the sensitization. VHS is Village Health and Sanitation Committee. With the NRHM, nowadays there is $200 with this community at every village level. That is 10,000 rupees in India and 200 USD. So that fund is for this all emergency purposes at the village level. But they don't know how to utilize these funds. So the frontline workers without training, they will sensitize all these village leader how to utilize this $200 for these emergency purposes. Because there are a lot of protocols, signing, the approval and that something, but because of decentralization, they will utilize this fund easily. And household decision makers will take timely actions. So this is our second delay. Generally, all the male members, they wait outside the home to what happens inside in the delivery room. They doesn't bother. Unless and until the pregnant woman who had excessive bleeding, there is a myth in our country, whatever the blood loss, that is good. Blood is bad. So they don't recognize whether it is 500, 600, 300, what sorts of. Unless and until she is unconscious because of shock, then everybody is running around where to go, what is transportations, the money is not available, then they go to the hospital, they have to do cesarean sections, again there is a problem, the blood is not available, referred to tertiary care, within that moment woman dies. So that is how this BPCR plan and decision makers. So timely Haran, and this is our outcome of this. So the role of frontline worker is very critical. Our main investment to get the maximum yield from the frontline worker, that is this. Now we have shifted our target from service provider to frontline worker in the community mobilizations. Because one ANM is for 10,000 population and she had so many other priorities. As I mentioned, she is busy in 15 days for polio eradication activity. And she is getting a lot of incentive for that. So why she comes for this work?
Is this the ASHA?
Yeah, ASHA. So that is why the role of this is very important. That is why our training, our counseling plays very important role. She plays in the villages. It's a flexible timing. She doesn't have to go to morning hours, afternoon hours, evening hours. Whatever the time suitable for her, for the pregnant mothers, decision makers should be available in the home, and she should. So these are the 6 topics. Antenatal care. So antenatal, she knows everything. But what is important in antenatal care? That is birth preparedness plan. She knows what is antenatal care, how many visits are important, 100 IFA tablets are important, TT injection is important. But looking at the PPH point of view, what is the birth preparedness and complication readiness plan? She should know. What are the danger signs of PPH she should be aware of? Intranatal care. So during intranatal care, as everybody knows, there are 5 cleans: clean surface, clean hand, blah, 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 all the things. We are not focusing on all these cleans. We are focusing on the physiological management of Amstel. There are 2 types of Amstel, active management and physiological management. At least I can understand she should not do, she is unable to do control contraction, even we are not promoting in the training, but she can do uterine massage and immediate breastfeeding. These are the 2 physiological management of PPH we are focusing in the intranatal care. And definitely everybody knows immediate breastfeeding has a impact on, at least for the uterine anatomy, increase the contraction and reduce the PPH. Postnatal care, yeah. Even in the hospital delivery, the PPH in our country is delayed PPH. Generally, there are some remnants, some retained placenta, they go to the home after 24, 48 hours, this sudden bleeding, that sort of. So that is why the role of postnatal care is there. That lady has to be observed up to minimum 6 weeks. So that is our focus is, she should be observed for any danger signs, fever, discharge, or any sort of bleeding. That is our focus in this immediate breast. Essential newborn care, family planning, counseling, anemia. Everybody knows family planning is a gateway or a pathway for improving the maternal health. So we are just sensitizing her. These are the contraceptive, you can use it. These are the available this much. Up to 6 weeks after pregnancy, this you can use it. So we are just sensitizing them what is available at the time. Then with sharing of information to interpersonal counseling in the IC. So we have developed simple tools as in the clinical interventions, simple IC material which is available at the village level, at the home level rather. I will come first. Orientation of VSC already I mentioned, addressing illegitimate maternity. Yeah. This is a tools we have developed, simple tools. So this is called as a birth preparedness and complication readiness calendars. So we are providing this in all these 1144 villages. This is of course in local languages. I should have brought in English, but this covers everything. So these are the danger signs of PPH. These are the 9 months what is required in the ANC. This is general information. This is hospital information, where to go. This is ambulance number. This is transporters number. Generally nowadays in India, every village has some 3-wheeler or something transportation there. So this job of frontline worker to sensitize that transporters. Don't worry about the money. We can collect our money from that village health sanitation community, and whatever your diesel bill or petrol bill we can share with you. So this all information is available in this calendar. Apart from this, underlying drivers of PPH, that is anemia. So what is there in the nutrition? That is there. The important counseling messages in our country completely missing. So like everybody says, take IFA tablets, 100 tablets. But no pregnant woman is take IFA tablets, because the counseling message is immediately after taking IFA tablets, she had a black colored stool. But nobody tells to the pregnant woman that, then she realized, oh, before taking tablet I am normal, and after taking tablet suddenly I develop some disease. And then she lied to the husband, she lied to the frontline worker, I am taking, that sort of. So that is why this important in anemia, what is required for that disease. Like eat green leafy vegetables, a glass of milk, 2 eggs. Imagine a poor woman in the community, it's not available. It's not possible in India, green leafy vegetables and anemia. So what is available at the local level, what she can eat to improve anemia. So that sort of short, simple messages we have created as IEC and given it to direct in the families. Another is, this is our flip charts where the frontline worker goes with the pictures. She will describe to the pregnant woman. These are the important messages. It's in simple picture and local languages. So this is all picture. This is the bags we are providing to the frontline workers during training. She can carry our registers to collect the informations. So this bag is, we have done the branding for these frontline workers because frontline workers are from the government side. So this is, everybody knows ASHA, but what is new is red bag with ASHA, that is Pathfinder's frontline workers, that sort of. That is why Shabnam has red bag with different purposes, but India team has bag with different purposes. So, thank you. This is about the community. I don't know if the questions are there or no. People are tired.
Thank you. Thank you to our panelists. Some comments or questions for this group. Community group is always forgotten. It's always the last thing, always forgotten. Yes. Ooh.
Yeah, please.
Determined by a government policy, whether or not you have set up a different parallel system, and you didn't talk about supervision. What kind of
Yeah, I missed that. Yeah. Yep. Thank you. Actually, this frontline worker is from the same community. So government has recruited one frontline worker for 1,000 population. If village has 4,000 population, so there are 4 frontline workers in that villages. She is from same community. Her selection for the criteria, she should be at least 8th standard, semi-literate, even not so many literate also. So this is selection criteria. She is available 24 hours in the village. She is from same locality. Because there are different caste systems, so looking at the caste system also, there is a recruitment is there. Regarding our Pathfinder works, yes, definitely there is a separate timeline because she had to devote more time for the government work. Because she is getting honorarium or whatever the money is for the government work, not from our side. But we have 6 visits we have planned. For every month, she should visit 6 times to that pregnant mother. 6 times with 6 different purposes. One is for antenatal, one is for intranatal care, one is for different purposes. And it's a flexible. It's completely not routine, the routine time that is 8 to 10 or that sort of. Whenever the pregnant mother's decision makers comfortable, because generally in our rural community, the female, whether pregnant or not pregnant, she has to go to the field to work for farm because nobody is allowed to sit that woman in the home. So naturally that work start at the evening hours. Our government work generally start during office hours sort of. So we get quality time to address the decision makers or target stakeholders during morning hours or evening hours. Regarding the supervisors, yes, we have involved local NGO partners. So there is a community mobilizers. They will do the supervision whether she is doing appropriately counseling or how it is doing, whether everything goes on right time or not. So there are community mobilizers for every 20 villages from NGO implementing partners. That's from Pathfinder side.
And I'm wondering, number one, are those up on the web? But I didn't see this community-based tool. And I do think we found that putting the AMSTL survey tools up on the web was people found it really valuable.
Mm-hmm.
So are the general tools on the web, and is this community-based tool available for others?
It is, and what we did with the, I can answer that if you don't mind. What we did is actually after doing the community-based survey in Nigeria and India, we refined the tool. You know, we sort of learned from what some of the mistakes we made, some of the answers we weren't very happy with. And so our research and metrics unit refined it so it's a good tool. And it is available in that toolkit, and the whole toolkit's on the website and on your CD.
Okay, so because I
You have it.
didn't see this, I went through the great.
It's not just
Thank you.
Yeah, it's in the definitely in the toolkit on the CD.
Okay, yeah, because I didn't look on the CD. So then one to Ndola, and I'm just wondering, oh gosh, I've just blanked. Oh, VSI has been so good and really the leader in the whole issue of registration and the issues around actually bringing misoprostol into a country. I know PSI has done a little bit, but I'm wondering whether there are some other folks now that are assisting with this, because that's a heavy burden to have to be really the experts and kind of the only ones that are helping with this. And is that, do you have a few more folks helping out?
Right. So yes, we do, and we usually don't work alone. Even when in countries when we say, "Oh, we register misoprostol," it's a collaborative work. We work with commercial distributors in many countries, and we also work with social marketers. So PSI, MSI, DKT. It depends on the country. But the idea is we do work in collaboration because sometimes, or most of the times, in order to register the drug, there is a lot of policy work that needs to be done before and during the registration, and also some registrations that are tied into the level of access. So we need to do the operations research to demonstrate that it's safe to be used and feasible to be used at the community level.
Now, those are kind of the people I tend to hear. No new names and groups that are helping with this yet? Just one.
No, not yet.
Is that an invitation?
But at the implementation level, yes, we have a lot more partners, working in, increasing access to the drug. But I was talking specifically about the registration process. Mm-hmm.
Thanks for that. Just nicely wrapped up the whole community aspect for the Pathfinder program. Maybe this is a reality check, and it's not meant to sound harsh. So your project in India has 2 million people covered. So feasibly to cover the country, you have to increase that 500 times. And I'm really wondering, you get government support, but where do you go next with this? Do you go by district governments to state governments? How do you sort of move up to really build support, maybe not from the top down, from the bottom down, to really get communities building and building and building? And the same, I guess, in Nigeria, because obviously it's a model that has success, but I think a couple of people have said do we need to start a campaign to eradicate maternal mortality from PPH? So if that's the case, how long should that take?
Go first.
Good question.
What's an acceptable time period in the
I
country?
think
Who needs 2 microphones for that one?
It's really a very, very huge challenge to have policymakers embrace the whole model. I think the biggest problem or the biggest challenge we have in Nigeria is that they are way, way, way more interested in the NASG than in the other components of the model. And it's really one of the, I think, reasons why it has not really been put to the scale which it deserves. But having said that, I think different people are taking the whole model and replicating it themselves. Pathfinder only does this in 6 states. Now we are just moving into the 7th state, and there are 36 states in Nigeria. But we have had the Ministry of, through the MDG office, they have now taken it to 16 more states. The Lagos state government, I think Lagos is one of the richest states in the country, they have taken the whole model and replicated statewide. So all the components of the project are in every health facility and every community in the state. The UNFPA in Nigeria also, I think they had some funding from the Canadian government. They also took the whole model and replicated in 2 states that they are supporting. it's really, really catching up on. The Federal Ministry of Health now, which should ideally take the lead on this one, has just zeroed in on the anti-shock garment. And they are planning to buy, in addition to misoprostol and magnesium sulfate, they are planning to buy these things, but there's really no talk about the community component of the model. And I think this is largely because they believe that the primary health care agency, which is the agency of the Ministry of Health that deals with community or primary health care, already has these village health or community development committees, which are supposed to be doing some kind of community work around safe motherhood. But the reality is that most of those communities, development committees, are very dormant. They don't have a lot of funding, and so they do not do a lot. When we went in there, we had to reactivate a lot of those communities. And even, getting them to come regularly for the monthly meetings, they expect you to, put some money on the table before you do that. So those are really some of the challenges that we face.
And Sudhir?
Yeah, I have to. Regarding this scale-ups, already you will be surprised, already the project has scale-up. Because previously, 6 months before, we are working in 4 districts in 4 states. Now we are working means with the government. Every state has 10 districts. And the cost of training and all the tools I have shown, the flip book, birth preparedness calendars, and everything is cost taken up by the government. FLW is already from the government. I don't know whether it is in country scale up. Yeah, population is too large. But already this is going to be scale up in the 4 states, this model. With the government cost, just we are providing energy. The second thing, about the PPH. Why we are focusing more onto the PPH? Because that PPH can be managed at the frontline workers level. ANMs and below ANM level. You can see the rest: obstructed labor, septicemia, abortion. These are the 3 important other maternal health killers which has to be addressed at the secondary or tertiary level. That is why the focus is more on the PPH, and more than 1/3 of that, and these are the estimated figure of WHO 2000, I don't know, somewhere they have done survey in 2000. This is 30% figure of the estimated figure, but maybe there are much more figure of PPH mortality. That is why the focus is more on the PPH. But for the scale-up model, already we have committed to the government and donors. Now we have taken PPH and eclampsia both, 2 major maternal health killers. So all these 4 states, scale-up model, PPH plus eclampsia. Thank you.
Thank you. Even though the question wasn't for me, but I just want to share with you my thoughts about addressing a timeline, a potential timeline to make an impact. I think that with the information that we have today, we can transfer that, and a lot of us have been working with the governments to provide all that and translate it into policies, into practice. And if we all work together to really increase both the coverage of protected deliveries, both at home and those who occur in a facility with effective technologies, the technologies that we know work, in the next 2 years, we can scale up a program in a country, and in 5 years, we will be here talking about really improvements in maternal health. But the flip side of that, and I'm very I can say that it is possible to do, but the political commitment needs to be there, because Pathfinder can organize an event such as this in 10 years and you'll be in the same place if in the next 2 years we don't do anything. Let's take, for example, just 1 minute. For example, we take a country such as Tanzania. The drug has been registered for PPH indication since 2007. We have completed, and the results have been accepted by the government and the major stakeholders that we can use misoprostol at the community level. The need for Amstel, it's not, and the oxytocin at facility level and the training of providers at facility level is something that is being contested at all. So we have the anti-shock garment has been demonstrated in neighboring countries. So the idea is that if we all work together, that in the next 2 years we can scale up those programs in Tanzania. I'm giving an example in Tanzania. 5 years from now, we will measure a significant dent, at least in one of the causes of maternal mortality, which is PPH. But if we don't do that, nothing is going to happen, and we will come back and discuss again. But I think that 2 years is a reasonable timing for countries that have already demonstrated that with empirical data from their own countries that something can be done, and there are ways of doing this by protecting deliveries that occur both in the facility and at home. And if we all work together in the next 2 years, we can make some progress. But if we don't, it's not going to happen.
That's great. If single disease, very small disease, very less morbidity and mortality, polio. If the polio can get attention of all the policymakers throughout the world, why not maternal health and PPH? Polio has, you imagine, you just go visit India, Pakistan, Nigeria, whole system is busy in managing one single disease. And every 3 years there is a huge outbreak. WHO is saying we can eradicate 2000, 2004, 2006, 2008. 12 years this program is running around with so many budget. But there is no focus of policymakers or intellectuals on the maternal health, PPH. But definitely this is possible, as you said, after 2 years. If we give attention to the maternal health, definitely maternal mortality is eradicated.
Thank you. Excellent.
Go ahead. Sorry, Raj.
Sorry. You want to go
No,
ahead?
go ahead.
Go ahead.
Maybe we're talking about the same thing.
No,
I mean-
I have something else. You go
Yeah,
ahead.
all right. We're all working together to reduce maternal mortality. And the whole afternoon, I've been waiting and waiting for someone to talk about linkage with other programs, especially family planning. And thank you, Sudhir. You did mention family planning counseling. Yep. Thank you for that. Okay.
Yeah.
Postpartum hemorrhage, as we all know, is associated with high parity. And a woman with high parity probably will have closely spaced pregnancies. And we have clear evidence based on an AID-sponsored literature review and meta-analysis looking at nearly 200 studies covering 30 years of data, where the experts came up with a conclusion that to reduce adverse outcomes in the mother and perinatal outcomes due to closely spaced pregnancies, a birth to pregnancy interval of 24 months is recommended, which means spacing pregnancies, or the equivalent of a birth-to-birth interval of 3 years. So to complete the picture of postpartum hemorrhage, reducing maternal mortality, I think that we should also look at linking with other programs, especially family planning programs, to time, space, and limit pregnancies based on a woman's fertility intention.
Thank you, May. Rashna.
Thank you. No, May, thanks for bringing up that point. No, my point is that to what extent have you been able to, through the excellent work you all are doing, have been able to get this whole management treatment and address the issue by bringing it into the pre-service and in-service training? You know, one part is we continuously work with people who've been trained and try to change their behaviors and practices. But another side is also, that's one part which is very important, but the other side is also as people are entering into the ASHA training, the short-term midwifery training and all, to what extent have the training curriculums been updated so that they can start, at least we start getting the new ones who are coming in, getting the skills and the knowledge they need to address some of the problems we are trying to tackle.
Regarding the AMSTEL, it is already updated training curriculum in our country. AMSTEL, it is there in the pre-service, in-service curriculum. Regarding NSG, yes, definitely Tamil Nadu, the state, we have started. AMSTEL is there already, but already they are including NSG also in that curriculum, SBA training curriculum. But the AMSTEL is already included in our country for the training curriculum, both. Mizoprostol, no, not yet. AMSTEL is there.
Well, in Nigeria, I'm glad to tell you that we have had the Midwifery Council, put the whole training curriculum into the pre-service training of Nigerian midwives. So as we speak now, all 88 schools of midwifery are using our training. They have, integrated into their own training curriculum.
So I can also say that it's being done in other countries, Ethiopia and other countries, where Zambia, etc., where VSI works with other partners. We have collaborated with professional associations who have revised curriculum both at medical school and midwifery school. Is so interesting that actually some of the materials they were requesting, or they allowed the providers to choose between a physiological and active management. Active management was there, but they say you can do this or you can do this. So there was no, background evidence saying, yes, you can do the physiological, but this is what, the Amstel is what will reduce postpartum hemorrhage. So that has to be revised. And as you know, this was done, some of these materials are really, really old. But yes, there's a huge effort out there to revise all of the curricula for medical schools, midwifery schools, to include the new information about postpartum hemorrhage in general.
In the is really got a stronger pre-service component than, say, the MNH or Access program had. And so I think they're really particularly trying to address this. So, I think there's a number of different organizations in their projects that are trying to do it, just like Ndola said. I guess the concern I have, and it was stated before, is putting it in a curriculum doesn't necessarily mean anything. So you say it's in all of the curriculum, but you also said they actually don't practice it.
Yeah,
so, back to Suellen and the drills, we have to ensure that, in fact, they're both competent and confident to practice it, and that's the challenge.
I will tell you my personal experiences. During my medical school days, Amstel is there in the obstetrics and gynecological books 10 years before. But I learned Amstel when I joined the Pathfinder. That's in-service, pre-service curriculum, you'll get answers.
Sharon?
Just another comment, building on what you've all been saying, but I think one of the big issues is the shortage of health workers altogether in terms of addressing this issue of scale-up. And also building on the example from India, InterHealth is working not in the states you mentioned, but in UP. And there, the focus on polio and taking the health workers literally 15 days a month to focus on polio only. You have children who reach school age and have had 32 doses of polio, but they're not doing any of their other activities. So you're talking about scaling up maternal health and the issues around maternal and newborn. There is nobody there to do it, absolutely nobody there to do it. And so the whole issue of, and also the other impact is that routine immunizations for other childhood immunizations is down to 30-something% in Uttar Pradesh because of the polio eradication.
Yeah, that's
campaign.
huge setback.
So you're taking your health workers, focusing on that, and leaving everything else out of the mix. So talking about taking something to scale is huge when you don't have enough health workers or they're focused on these other interventions.
No, the problem is the ANMs, midwiferys, are involved 15 days in the polio eradication activity, not ASHAs and Anganwadis. So our main focus in the scale-up and in the community mobilization, not ANM at all. We have not involved ANM anywhere in the community mobilization. Only ASHAs and Anganwadi workers. Anganwadi worker is, that's midday meal school and nutrition and non-formal education gives in the school level. So there are two frontline workers at the village level. One is ASHA, that is an Anganwadi workers. They are not involved in any programs, any drives. Only the national rural health missions, that is maternal health, that is institutional delivery, that sort of. Another issue you read, good point, that is about the vaccine preventable diseases. Recent study, I don't remember the journals, because of polio eradication drive, mortality has increased in the children because of tuberculosis meningitis. TB has increased. Diphtheria deaths are increased because of polio eradication. The families or couples in our country now, they think that if we take 6 drops of polio or whatever 30 drops of polio, the immunization is complete. They don't know other vaccine preventable diseases also. Polio is equivalent to the all 6 vaccine preventable diseases. That's equations now at present. And that still we are believing in WHO.
Okay, thank you all. And I think maybe we should take up Ndola's challenge and be here in a couple of years to see where we are. Another reality check. Where are we then? But I want to thank especially all our panelists, who many of whom have come from such a long ways away and have prepared so well. So I want to give another hand thank you to May and to our panelists. And as you can imagine, there are many people who put this together behind the scenes, and I wish I could be here to thank all of them, not just from Pathfinder, but from many of the other organizations. But I just want to say a special thanks to 2 people, Callie Drake back there and Myra Nicola. Thank you. And I also want to thank the MacArthur Foundation that funds our project in both India and Nigeria. And not because they helped us introduce a new technology, but because they really stuck with us to do a comprehensive model so that we come at postpartum hemorrhage from all the different directions, not just through one new innovation, but also the World Bank that funds Shabnam's project, to bring it down to the community level and help empower women. And also to Dawn Shapiro, I hope you do watch the documentary that's in you have a little voucher for the documentary film that you can access on the web with that special password for a limited amount of time. Callie, do you know how long the time is? 2 months? 2 weeks. 2 weeks, so watch it quick. Okay, thank you all for being patient listeners and contributing so much. Thank you.